Hi, my name is Dr. Rudra Mohan, and through the Oral Health channel today we're going to be talking about maxillary canine and mandibular canine impaction. Let's start. So I'm going to be talking about canine impaction at large because of the fact that we recently had a case and it was a very interesting case. So I thought I should spread the awareness about why maxillary and mandibular canines are impacted. By impacted, it means that they are not able to come into their functional position by penetrating the gums and coming into their occlusal position because of various reasons. The reasons could be early trauma, cysts, supernumerary teeth, any sort of retained primary teeth, any sort of ankylosis which could be present, and the causes are a lot. They could be genetic causes. Some sort of genetic syndromes also have these things, and the maxillary canines are the ones which are the most impacted, commonly impacted teeth after the third molars. You have to understand that. Now, since they play a very important role in canine guided occlusion, it is absolutely necessary, if you have a patient or someone you know who has impacted canines and who wants to undergo some sort of orthodontic treatment for aesthetic or functional purposes, you do require the canines to be in position, and if they are impacted, they need to be either surgically exposed or somehow brought into occlusion. Depending upon the etiology the case is planned, if you have retained primary canines, you might have to get them removed. You might have to undergo some orthodontic extractions as well to sacrifice the premolars so that you can get the canine guided occlusion. On top of that, you have to really understand that it depends upon what kind of impaction is present. Now, in females, the ratio of canine impaction is 2:1 compared to males. The buccal canine impaction is more prevalent in the Asian population, and it all depends upon some criteria that is based upon the the labiolingual position. That means in what plane is the canine lying impacted, either it is buccally or palatally, or on top of that the mesiodistal position, as in if it's tilted, how much bone is covering it, is it partially covered, is it fully covered, is it partially obstructed, fully impacted, and also the amount of keratinized tissue width and gingiva present over it depending upon the location, be it buccal or the palatal side. Now, this is decided after doing the careful evaluation of the patient clinically, where we see the age of the patient, the gender of the patient, the arch size, and we do various analysis in orthodontics just to see what is happening, which is corroborated with the help of radiographs to check if there is any sort of arch tooth discrepancy, and on top of that you can get to know what the exact location is. However, in routine radiographs you will just get a 2-dimensional image, so it is always better to get a 3-dimensional cone beam computed tomography, that is a CBCT taken, so that you can visualize the plane in which the canine is found, the depth of the canine into the tissue, that means the distance of the canine tip from the alveolar crest, and also the kind of location that it might be having in the labiolingual or mesiodistal position. So depending upon the case planning, you have surgical exposures of canine, which is open exposure, closed method, and you have apically positioned flap, especially for areas where there is not enough amount of keratinized tissue width, which can cause gingival recession when it comes to canine exposure in that area for shallow vestibule. So it is always better to go for apically positioned flap and thereby preserving the attached gingiva, and you can also go for closed exposure of the canine with the help of removal of the bone and then closing it back. And finally, the best thing is the open exposure that you can do, especially in the palatal areas when it is almost crowning in through the palate, where you can go ahead with either electrical scalpel, although that causes a lot of post-operative discomfort. You can go with the conventional cold scalpel, but that causes a risk of bleeding, and you can go for laser. Now, in our practice we have recently done a laser canine exposure, and that for that we placed the patient under local anesthesia, and the beauty about lasers is it's absolutely bloodless, and the relative post-operative pain is much less compared to the rest of the treatment modalities. And depending upon the case, the orthodontist will plan the thing and they will expose the canine and then probably place a button or an attachment or a bracket, and then they will, with the use of anchorage and elastics, they will try to bring the canine into occlusion. So this was today's episode. Please like, share, subscribe, and do press the bell icon button for important updates. If you want to get in touch with me, here are my social media handles. Kindly refrain from calling me directly, as I might be busy with patients. Just drop me a message on WhatsApp with your name, your location, and the common oral health problem that's kind of giving you discomfort. And if you have any queries, doubts, apprehensions, please feel free to put them in the YouTube comment section and I'll get back to you shortly. So that's it for today. Thank you.